And I think this reinforced me the opinion that usually the real specialist is very specialized and just looks his own piece of intervention. However, in these cases, or there are some cases, in which we have a lot of contrasting needs. Let's see, we have I think the previous case was a good case. We have abdomen one part and respiratory failure the other part. I perfectly agree that the timing was completely different in the occurrence of the two things. But let's see, the man like this had also a brain trauma, which is possible in an incident like this. So everybody knows if you look, you call my French interior or whatever, neurospecialist will say, okay, for the brain, I have to control the oxygen supply, I have to control the flow, I have to control the edema, I have to prevent the increase of intracranial pressure, and to do so, I have to provide adequate oxygenation and adequate flow. But my problem is also this patient have a severe thoracic trauma. And maybe if you take a book, when you have a trauma, what you do? You have fluids. Where the fluids go? Where they want, not where the doctors want. We would like to have the fluids in the vein, but and the arteries. But very often the fluids go a lot in the interstitial part and into the cellular compartment too. And so maybe to keep the patient alive in terms of respiration, we have to use some positive pressure. And positive pressure means I have to increase the mean airway pressure. If I increase the mean airway pressure, okay, I have some problem to ventilate the patients because the patient has the trauma, the ventilable lung becomes smaller, PCO2 usually goes up, which is not good for the brain. So if you go to the lung specialist, say, okay, let's do some pervasive hypercapnia, keep the patient quiet, put the lung at rest, great. And the other side, well, you need to hyperventilate the patient and to decrease the PCO2. And well, we have also surgeon. This patient had also the trauma in the abdomen. And the abdomen is very, very dangerous place to have a trauma or to have incident. But anything I do to the lung or to the mean airway pressures, it reflects to the pleural pressure. If the abdomen is also impaired, I may increase the pleural pressure. The pleural pressure means, an increase in pleural pressure means that whatever comes into the thoracic cage, I have a problem to receive it, and I have a problem to the outflow. So, this is a problem, what to do? Sometimes after years of intensive care, one thing that I thought is sometimes it's better to sit down and to think and don't doing nothing. Because I don't know, but I saw so many terrible accidents at 3 a.m. The doctor is alone, there is nothing to do, and the day will come, well, I have a good idea, great. Very dangerous. So consider always all these kind of things. So in acute brain lung injury, key issue is the pleural pressure to me. Now, just a question, how many of you do measure the pleural pressure continuously? So, sit down. Sit down and take rest. Because, my dear friends, if we do not measure, we do not know. Sometimes it's better for the heart. You live more quietly. But, it's completely different if I have a high pleural pressure or a low pleural pressure. And we developed also a vessel and a urinary catheter, in which is a Foley catheter, in which we added a little balloon with the same material that we use with the balloon for esophageal pressure. So we may have a continuous abdominal pressure. Because abdominal pressure is another problem. How many of you do measure abdominal pressure through the blood? Great. How many milliliters? 50, 100, 75? What's the temperature of the water you put in the bladder? And then you say, up to 12 is normal. After to 25, well, wait a second. How do you measure? It's a quite complicated measurement. Apparently it's easy, but when you are borderline, you have to be extremely careful. When you have doubt, I had it in my life one time. I was called in Switzerland, a young man who went down from Saint-Gothard, crashed, and he had a terrible trauma in the lung, and the abdomen per se, nothing, but the wall of the abdomen was full, with blood inside. And I tried to measure the blood pressure. It was extremely high. The patient was in dialysis. So we called the surgeon. This was German surgeon and Italian Swiss. You can imagine, a very common Italian. They say, oh, you're crazy, don't know it. So I stayed with the surgeon 1 hour and a half, and we constructed the volume pressure curve of the bladder. This is no question. When you reach this is the real measurement. Particular case, he was convinced to open up the abdomen, to leave abdomen in 24 hours. The kidney started again. Well, was a fortunate case, this one. Anyway, for the brain, whatever increase in pleural pressure and PCO2 is bad, and the other side, so how can we trade off? And I don't think there is any rule, any guideline, any ABC, any score, which can help more than sitting down and carefully think of what you know about the physiology of the system, and to see which were the priorities. The case we heard before, the priorities, my God, clearly was the hemorrhagic shock, more than breathing. The breathing was the last problem, was the end of a story. Was not even on a respiratory failure. It was a natural conclusion of a multi-organ failure in which the patient, I can imagine, gained in these 3 days of hospital at least 10, 15 kilos of water. Because you can imagine the amount of the whole attempt which has been done. So handling PPL and CO2, we have some instrument. Open the abdomen is the last, of course, the last bit. This happened, but you have other possibility. Let's see. First, we have to understand, for what the lung is concerned, that what moves the lung is the transpulmonary pressure. And what moves the thorax is the pleural pressure. So when you put here condition like this, let's see, we have 25 to move the lung, 5 centimeters to move the thorax. Here I have 15 and 15. Let's see, I have my patient, I read in both cases 30. In this case, in terms of priority or possible damages of ventilation, I know that I'm killing the lung because 25 of transpulmonary pressure you reach at each breath the total lung capacity. Try to imagine, take as the deepest breath you can. Try to take for 3 times. You feel it to be uncomfortable. Try to take for 15 times, 20 times per minute, or for 1 day or 2 days. You take a normal animals, you kill. And this with the 3rd day here. So if I use this approach, I have some problem here. But I have to know, because in the other side, if I have this one, 15 is very well tolerated. So I can ventilate for days. But 15 of pleural pressure, I have a problem with the hemodynamics. Because there is no question. We have one thoracic cage, we have 2 sacs, which are the lungs, which wins. Because when the lung is inflated, become as a stone. The heart is in between and is full of holes. So the lung is squeezed. Less blood coming in, less blood coming out. And at this level of pressure, this becomes a problem. Then I can add all the monitoring I want. But I have to understand first what is the first problem in this particular moment for that particular patient. And without measuring, it's just impossible. For a PCO2, let's see, a reasonable trade-off. Well, if you take a book and say, oh, the patient has some bilateral infiltration, a little bit wider, measure the compliance of this patient. If the compliance is 35, 40 or greater, means that more or less 50% of the original lung is still ventilable. That means you can use even terrible thing as 7, 8 milliliters of oxygen per tidal volume. Don't be blind in looking, what's it? Because 12 has been shown in great studies that kill the people. No, wait a second. 12 has been shown, we have 15 or 20 patients more died in the treated group with 12, but the difference was 6%. We have a lot of other patients who survived with 12. Why they survived? Who were the patients who died more? Of course, they had something different. In that group, the patient had a compliance of 50 or 60, or even 65 or 70, as in some patients. In that particular patient, you don't kill anybody. So look also at this number with a common sense. And you have to put this number, this knowledge, in the total framework of the patient that you are observed. Then we have a series of alternative methods. Now we have the high flow oxygen and so on for washing the dead space. Well, if you take anesthesiology, 1952 has been already described. There is nothing new about the sun. So we have a series of, in some cases, you can try to add, but not just a practice or as a dogma. In that particular patient, you have a particular problem. If what you have to use is not particularly invasive, only think what I am harming, benefit and harm. What is likely to have more? With intragastrogastric insufflation is no problem. High frequency oscillation now is the devil. Once again, it depends on how you apply this. And the extracorporeal CO2 removal is great technique to control the CO2. But per se doesn't save any life. So when I have to use this one, I have to balance the necessity, as an example, of the anticoagulation. The poor man described before. had a tremendous coagulopathy. His problem was bleeding. Putting an extracorporeal supporter would be, in this mess, increase a little. For what? But in some case, if I have a brain trauma and I use the extracorporeal support, remember that the real complication of the artificial lung is just one, the lethal complication, which is the cerebral hemorrhage, which is 5–10%. Even in patients, maybe we start with normal platelets, and without any sign I saw in my life, a patient apparently perfectly okay, that suddenly goes in cerebral hemorrhage. This is why I always been extremely prudent in using this technique. Because if the patient bleed from the wound, it was okay, it's not a great problem, a little bit of compression, call the surgeon. But if you bleed in the head, it's a disaster. So when the people say the preventive use of extracorporeal support, be careful. Anytime we add an artificial organs, we may have some problem. I heard a discussion on prone position. And if you take whatever papers on prone position, they said that prone position is contraindicated with a hemodynamic instability. Why? I think for only one reason, that if the patient goes in cardiac arrest, it takes time to put the patient in supine. Because per se, the prone position to the hemodynamic doesn't do absolutely nothing. We measured for 30 years this kind of thing. And I don't remember any drama putting a patient in prone position, which does not exclude that occasionally, maybe it may happen, so okay, stop it and put it in supine position. It's not an absolute contraindication, normally. And with the prone position, remember that you don't change the pleural pressure, but you may have, in about 50% of the cases, some decrease of CO2. And whatever stupid thing you are doing to the lung, the effects are better than in supine position. Because the prone position is nothing else than the arrangement of the lung to put the lung in condition to accept better, without less damage, whatever bad we do to the lung itself. When you say protective lung ventilation, protect who? We protect the lung from us. Because we are the danger to the lung. We do not protect the lung from RDS, we protect the lung from the bêtises that we are doing to the lung. Anyway, oxygenation improve in this condition, in prone position. I don't want to make a story on prone position. But, if we have a patient of course, if the patient has some problem with the head, you have to be extremely careful in studying and not to have any impedance to the outflow. So the position of the head become crucial. That maybe in other patient is not, but in this patient may be important. And of course, let's see, I have a patient I have to put in prone position because some terrible problem in the cerebral, in ICP, with the prone position I can decrease, I can have a better trade-off, just decreasing maybe more the PEEP and then assuring normal oxygenation. And if I put in prone position and I have the monitor, if I measure, I know exactly what is going on. Before I can suppose what to expect. But the monitoring tell you what actually happened when you do it. And you may say, okay, what's wrong this time? Back. Maybe it's better than to discuss the topics for 10 days it's easier sometimes to. And with a prone position, we have a series of things, but as an example, the beds that Joseph was quoting before, some suspension which normally is not useful, but in some particular patient may help. So the disadvantages of prone position, the head position, the head should be very carefully checked, the position of the head. And the prone position, I think these are meta-analysis. No, it's a single patient. In a patient with severe ARDS, work. About 1 patient over 10. Severe, I mean underfit. Here were 100, less than 150 of PF. Here, less than 100. In both cases, when the PF is at that level, below 150, the amount of lung edema is consistent. If you have 250, it's not. And so until at that stage, it's absolutely useless to use, as an example, prone position. The preventive use of prone position is absolutely nonsense. We know that. Should be applied only when the things are at that stage. Before, it's just useless, and you had also only the harm and the disadvantages and not the advantages. And then the abdominal pressure. We have also with my friend Manu Maldrela, the International Society of Abdominal Pressure, and so on. It's a fashionable and is an important argument. But what is the abdominal pressure? I wonder is asked, how can I measure the abdominal pressure? Of course, the abdominal pressure is not the same close in a supine patient, close to the umbilicus, to the wall, and down. And it depends on the size of the patient, but you may feel 6, 7, 8 centimeters. In the most innocent and the most rough model that you may have on abdominal pressure, if you look at what is the abdomen height of the patient, you can more or less estimate by the density of the abdomen, let's see around 1, if it would be pure water, well, you know that should be around 10 or 12 and so on. If I have more pressure, I have only 2 possibilities. Or the cage has been reduced, and the elasticity of the cage has been reduced. As an example, when I have a wall, infection into the wall, or when the content is increased. So in a case in which I increase the amount of a bowel because of gas or because of edema, and this may happen very rapidly. This is why I think the continuous monitoring of abdominal pressure, all these patients are in Canada, a continuous monitoring of the abdominal pressure can tell us, and abdominal pressure has a lot of effect. Look here, this is the very patient with quite severe RDS and expiration and inspiration. Here we increase a little bit abdominal pressures, just putting a couple of kilos. So that means that the abdominal pressure will increase a few centimeters of water, just to take the CT, and you see already the difference. If you are less gentle with these were the German pigs, and you can see that when you have oleic acid, this is the distribution into the lung. You see green. Then you increase the abdominal pressure, pop, magic. And you see the amount. What's happened here? Why? Because a sudden increase, in this case, of abdominal pressure, pushed all the blood immediately in the thoracic cavity. And we have a big transudation into the lung. So we have to be extremely careful. And what's about we played with extra-abdominal pressure with a negative pressure, and which is in some cases, well, I think it's more a physiological experiment than a possible clinical practice, although we applied in some cases. You know, this is the way where you measure the abdominal pressure. When you are in the bladder, we measure approximately the middle level of the abdominal pressure. Here is lower, and here abdominal pressure is higher. And of course, when I put a patient in a position, play a lot in terms of movement of the application of the gravitational forces. So more the patient is less supine, more I relieve the lung from the problem of the abdominal pressure. The negative, these are pigs. Now you remember maybe the oldest of you is a poncho in the reverse side. We were using PEEP and looking at the central venous pressure. And you see, this pig has the abdominal, this was the abdominal pressure. And we were using, as an example, with abdominal pressures of minus of 20, we were putting minus 20. And you see that clearly it's possible to manipulate the central venous pressure with ACP. What's about the man? This is the man with an abdominal pressure, and you can see that the negative, these are 20 patients, and you can see that with the intra-abdominal pressure, let's see you have in this condition as this condition is 12, which is normal. Okay, I put a sort of punch around. I put minus 20, minus 12. And I have a decrease down to here of about 4 centimeters of water. Then I put minus 12 plus another 5 of negativity, so minus 17. And become here, and here comes at 10. Well, we did that in brain-injured patients. And brain-injured patient was quite curious because this was the abdominal pressure at 12, 7, so we put a negative pressure of minus 12, here minus 17, here's minus 12, here minus 17, and here minus 12, minus 22. And you can see that you have some delta YAP, which is about 4 centimeters of negative pressure applied, about 0.3 centimeter going down into the abdomen. And what's happened to the intracentral? Look, I'm playing with the abdomen, and I'm going to look what's happened in the intracranial pressure. And you can see there is some tendency, 17, 15, 15, 15, so who cares? But as usually, in medicine, when we put together the things, we do not understand anything. If we try to understand which are the mechanisms, what's happened, you see that first that you have some patients which come from 19 to 14, which is not spectacular, but the maneuver doesn't cost almost anything. And in some patients, absolutely nothing happened. Which are the difference? In both the two cases, in responders and in non-responders, we have a decrease. Now I can put here, and you can see these are the responders. And you see that the responders were the patient who started with abdominal pressure greater than the non-responders. That means If you have a patient with a brain injury and the abdominal pressure is normal, nothing happens if you change the pressure, if you decrease the pressure. Normal is normal, yeah. But if you have an increased abdominal pressure, because it's not immediate, you may have a decrease and so on. And the amount of decrease is about half of the centimeter of water that you decrease in the abdomen. So, we have a lot of interaction, brain, lung, chest, diaphragm, and so on. And my conclusion, when you have, we had with some frequency some conflict between lung and brain, we play a lot with not being dogmatic with the 6 milliliters and so on, depending on the compliance and depending on the status of the patient. The position may play a relevant role, and I think YAP is a key issue. But at the end of the story, my dear friend, what is important is to continuously measure what's going on, both into the esophageal balloon and both in the bladder. I thank you for the attention.
Okay, any questions from the audience? Luciano, thank you for this very complex matter which you have gone from one system to the other and tried to combine it. And just maybe a comment or experience from the prone positioning and hypotension. I always say, look at your catheter with noradrenaline infusion if you have hypotension first. Yeah.
And not the kinking of the catheter.
Exactly. Because that has happened, I mean, these sort of things. Any questions in between? What would your, because you have concentrated more on the brain, lung, and abdomen in general, because they are the real big problems. When you are systematically thinking, what is your attitude? Where do you begin? Because you have, at a certain moment, that's the sit down and wait business, because you have 3 or 4 or 5 problems there. And you cannot sometimes make it better all at the same time. How would you begin to that? Just set of mindset, yeah.
Okay, I think what the general rule is we have to divide the therapy. I mean, I divide the therapy in 3 big areas. One is the cure of the problem. And the cure of the problem, as an example, may be the surgeon, which... the other one is the cure of the pathophysiological process leading to the symptoms. As an example, the cortisone, the anti-inflammation, this kind of thing. But what makes the intensive care is the cure of the symptoms, which are life-threatening. That means my priority is of the symptoms, and the symptoms may be respiratory failure, depression, the kidney, of all these symptoms. What is the one which more rapidly may lead the patient at death? And I try to concentrate on this in terms of priority. So, there is not a unique rule. This is why I think to sit down and to think is quite important. I'm afraid of all the protocols, because the protocols, reflect better a protocol than a big mess. There is no doubt. But more than the protocol, sometimes the protocol cannot take into account the variability of little things that may happen. And to me, as an example, the 6 milliliter ventilation is one good example. and we renounce to 6 milliliter ventilation, which kill in severe RDS 6% more of the patient than if I have to control an hyperdynamic.
Just maybe a little bit outside our scope, but can you also elaborate, because I know that there are a lot of colleagues, if we give 4 milliliters or 5 milliliters per kilogram tidal volume, they would feel that the patient is extremely safe in lung damage. But do you share that view?
I mean, if you use 5-6 milliliters of tidal volume, you have to be extremely careful, because you are usually in this patient, which are full of the space on, you're having hypoventilation. Hypoventilation means that less gas goes in that particular part of the lung in the unit of time than sometimes the gas which is drawn out from the blood. That means after maybe 3 hours of gentle low mechanical ventilation, you increase your absorption of telectacy of 10%. And you don't see the telectacy, but maybe the saturation goes from 90 to 88, and you say, well, 88, I'm protecting the lung. Remember that the oxygenation is the last things to change, because you are well equipped to rearrange our circulation in the lungs to protect versus the hypoxemia. So we put more blood in the good part. But the heart has to pump against one lung in which I have a progressive atelectasis. And then maybe I have some problem maybe with pressure. Pressure, you take a book, what you do there? 2 liters of saline. Track, get it. After 3 days, you have 15 kilos more in the patient, no fluids in the abdomen, no fluids in the vein, in the artery. Sometimes more I proceed in thinking of, and I examine all the evolution we had in intensive care over 30 years. I think that we were always right since the beginning, qualitatively. But we did quantitatively the terrible mistakes over the years. Tidal volume is higher, CO2 must be great. At the beginning, 15 of tidal volume. Now, well, tidal volume is very dangerous, great, maybe dangerous, so 6. 6, you know. If 6 is better than 12, 4 will be better than 6. And 2, what is the problem? I put artificial lung. Then I found a moderate RDS with a cerebral hemorrhage instead of reading a newspaper. You know, you have to be very careful in marrying the ideas and marrying the dogmas. Use always your brain. I appreciate a lot the intervention of the young doctor before, which took this dangerous apparatus, which are the helicopters, and go and says, oh, what is better? Now, my priority is the shock. If I stay here to play with the tube, and then anytime I put one tube somewhere, you never know exactly what's happened. Usually, okay. But maybe you have a hole like this in the lung into the parenchyma. So, careful. But I'm too old for this much.
Okay. Thank you very much, Luciano.